2024. Thank you all for coming. In advance, I'd really like to thank our team. So starting with our leader, Patrick Waite, Webb Bierbrier, of course, Jeff Michalka, David Santisanio, Laura Nichols, Ellie Gates, Rachel Charbonneau, Chris Aaron. So we couldn't do this without the whole team. Also, especially want to thank our exhibitors for being here. And then finally, all of our presenters. We have, over the next 3 days, over 100 presenters just in our event. But we're going to kick it off today with one of our own AHA colleagues, Dr. Lori Witzel. She's going to talk about the exciting work that we're collaborating with on the Physical Activity Implementation Guide. So thank you, Lori.
Thank you, Pat. It's so great to have the invitation to be here this morning. Tell me if I'm too loud. It's really a pleasure to be able to give you an update on the things that we're working on with the Physical Activity Alliance. And I'm just going to dig right in. So there we go. I'm going to talk to you about our effort around It's Time to Move. This is our policy and systems change focus on integrating physical activity assessment, prescription, and referral into healthcare delivery. And we're doing this work with the Physical Activity Alliance. This is a national collaborative that we've pulled together of organizations across the country in the space of across multiple sectors, and coming together to speak with one voice on the importance of physical activity promotion, really focused on national policy and systems changes needed to promote regular physical activity, active living for everyone. We have 19 board-level organizations, but we reach over 100 others with the different parts of work that we're doing. We have multiple initiatives, but our main one is our It's Time to Move campaign, and that's what I'm here to talk to you about today, because there's just so much synergy with all the great work that Pat and Patrick are doing in the Center for Health Technology and Innovation. It's a multi-year project, multi-pronged with numerous government agencies, quasi-governmental agencies, and other organizations. It's got, it's interesting because what we've been doing as we think about this is let's address each of the barriers that exist in making this happen, and let's try to knock down those barriers one by one. So first is, do we have standardized measures in the electronic health records that clinicians can use to talk to their patients about their physical activity? And so that's what we've been working on over the last year and a half. And I'll take you through our journey, but that's the first part of our journey. And we've been working in HL7, International HL7. Their process has been, working with a really great technical consultant to help us build out an implementation guide that creates the coding and the language and so forth that makes it integrated into electronic health records. We're working very closely with the Department of Health and Human Services. We have a memo of understanding, and we're there to support the physical activity guidelines for Americans. Just so you know, I want to put it out there that the next update of those guidelines is going to be in 2028. We're already laying the groundwork for those. The last guidelines were actually, it's really cool, were released at our scientific sessions here in Chicago in 2018. So we're getting ready for 2028, working closely with HHS. We want our work to be guidelines and evidence-based. So as we assess for physical activity, we kept it very much in line with what's in the guidelines and what's been validated in the literature. So the core assessment measures are how many times per week are you doing muscle strengthening activities, and then how many minutes of moderate to vigorous physical activity per week is the aerobic component. And so then we were working really closely with an expert advisory group to continue to build out this implementation guide, and it not only handles the assessment of physical activity, but also the prescription and follow through, the referral and follow through. So it's the whole continuum of care. We're trying to bring that implementation guide to life with new apps that we've developed, both smartphone and web-based apps that allow for providers and patients to put these on their phone or work off of their computers to be able to exchange information about how they're doing with their physical activity. And we're hoping to be able to put these apps out there into the public domain very soon for anybody to use, make better, improve, and integrate into their systems. Working closely with Pat to make that happen, and we hope to be able to share those. Beyond patient care, though, it's really important. We work really closely with the CDC, and it would be incredibly powerful to have physical activity data in the electronic health record. I'll give you an example of this. During the COVID pandemic, Kaiser Permanente is one of those health systems that has been doing this, has been assessing for physical activity. They were able to look at their patient data during COVID and see that those who were more physically active were having better outcomes from COVID in terms of hospitalizations or mortality. So they published those data in the peer-reviewed literature, and CDC took those data and expanded the analysis and put out revised public health guidance during the pandemic that physical activity was something really important that you could do to improve your chances with the disease. So we are excited about the idea of getting this more standard across the country into electronic health records so that we can make those comparisons between physical activity and health. But also it's an important supplement to our national surveillance systems. We do have gaps in our national surveillance systems, and having this real-world evidence right there at our fingertips would be incredibly valuable. Okay, it's one thing then to have standardized measures. It's another to actually get them into EHRs and integrate them into patient care. So we worked with the new Assistant Secretary for Technology Policy. That's a new department in the Department of Health and Human Services, and the Office of the National Coordinator to get physical activity into the U.S. core data for interoperability. So this is the core data set that is required in all electronic health records. And we were able to work through their process starting in September 2022. By July of 2023, we talked to their expert advisory groups and worked closely with the team at ONC. They actually approved our application to have physical activity assessment included in version 4 of US CDI. And now version 5 has been published, and physical activity assessment remains in there under health status assessments. So now it's in there in the US core data, but now we've got to kind of mandate that EHR is integrated into their systems, and that's done here with this rule that is proposed, hopefully will be finalized soon by the Department of Health and Human Services. This will require that all EHRs get it into their systems. So this is one piece of this work that we're doing. We're now pulling together a collaborative in North Carolina to bring all this to life. We've brought Epic, health systems, community-based organizations, North Carolina Department of Health, and other really important partners together to show that we can get this accomplished, including payers, and then make it all kind of a demonstration that we could then scale nationally. We have to work on paying for the exercise prescription, so we're going to be getting into that space in 2025. And we're convening a roundtable in December on benefit design. How do we pay for supervised exercise therapy? For whom? For how long? And then finally, we're going to be working on financial incentives. How do we align incentives to incentivize that this happens in the context of patient care and delivery? So those are some of our key work streams and next steps. I don't know, Pat, if we have the opportunity for questions after or during this, but I'm glad to hang afterward and would really love to talk to you if you have any interest in the work that we're doing. Thank you so much for the opportunity to be here this morning, and really appreciate the chance to give you an update on what we've been doing.
Hi, everybody. Pleasure to be chatting with you here today. Alex Sandu from Stanford University. Here are my disclosures. This work was funded by the AHA. So I'm going to be speaking a little bit about work that we've done as part of the AHA's Health Technology and Innovation Strategically Focused Research Network. This is a collaboration between University of Michigan, Stanford, Cincinnati Children's, Boston University, and Johns Hopkins, sponsored by the AHA, along with partners at Universidad Federal de Minas Gerais in Belo Horizonte, Brazil, as well as University of Washington. Our project really focuses on the suboptimal use of guideline-directed medical therapy for patients with heart failure. This data comes from the CHAMP-HF registry, which is consistent with a lot of other data that not only is medical therapy suboptimal across patients with heart failure and systolic dysfunction, but even for those on therapy, the vast majority are on suboptimal target doses. Our work and our collaborative project was really framed by this, I think, paradigm-shifting trial by Larry Allen called the EPIC-HF trial. This was a trial done by Larry Allen and University of Colorado as part of the AHA's heart failure SFRN. They took 290 patients, and they randomized them to either usual care or a patient activation intervention. The intervention was relatively simple. It was a 3-minute animated video about the benefits of heart failure medical therapy and a checklist that told patients, work with your clinician to make one positive change. That relatively simple intervention led to a 19% absolute increase in medical therapy intensification at 30 days, much larger than what's seen with many other studies in this space. So I think this study really kind of emphasized the potential opportunity. If we can give patients the information about where the goalposts are, they really can be their own best advocates for improving quality of care. So that is kind of the underlying theme for what we're trying to do with our collaborative heart failure project across these 7 centers. We're trying to basically take what they did in EPIC-HF and build a digital analog version of that we can really scale for activating patients around heart failure medical therapy. We built the Engage-HF app and piloted it at Stanford, and we then subsequently adapted it and are going to be doing a multi-center trial starting early next year. We actually had kind of an adaptation to a Brazilian version of that app led by Luisa Brandt, the Opt-HF app, and they're now in the process of testing that across multiple hospitals in Belo Horizonte, Brazil, as part of the Opt-HF trial with results hopefully next year. There's actually a great session tomorrow, I think it's at 11 o'clock in the AI and heart failure session, where they're really going to describe that reciprocal innovation process. So I'd really recommend that, as I don't think we have a lot of examples of apps in this type of setting being kind of adapted for healthcare setting context. And then we're also adapting the app for rural primary care clinics in Idaho and going to be testing that in a multi-center trial led by Chris Longnecker early next year. But what I'm going to be talking about today are these educational videos that we embedded within the app. Our fellow Zara Azizi made about 15 educational videos that are about 3 to 5 minutes in length. They focus on heart failure medical therapy, lifestyle, monitoring, and other kind of elements that are important for heart failure patients to manage their own care. I'm going to show you a brief clip of this, if it works. Probably won't, but let's see. Yeah, I don't think it's going to work, so we'll keep going. After we developed these apps, we embedded them inside of the app. We did a lot of feedback and pilot testing with patients. And a common question that we got from either clinicians or from patients is, are we sure that these apps will actually be preferred by patients, especially older patients with heart failure, compared with just having text versions of the education? So that's what we set out to understand in the Educate-HF trial. We wanted to compare patient preference and knowledge attainment between animated educational videos and infographics with similar information. So for this trial, what we did is we compared educational material delivered by the animated video versus infographic text. We focused on education around guideline-directed medical therapy, specifically ARNI and SGLT2 inhibitors. And in terms of lifestyle, we focused on blood pressure and weight monitoring. We took participants and we randomized them to one of 4 different arms. All participants would receive an education module on medications and an education module on lifestyle. But we randomized them which one would be via video versus which would be via text, and which one would be first versus second. All participants completed a pre-test of 12 questions about heart failure lifestyle and heart failure medications, and a post-test after they completed the educational modules. All the questions were covered in the educational modules with the same exact information in the educational videos as well as the text. We also asked patients about their preference and their own self-assessment of their knowledge of heart failure medications and heart failure lifestyle management. The educational videos were about 4 to 5 minutes, and we estimated it took about the same amount of time to read the text. As mentioned at the end of the assessment, we had 12 questions. 6 were about lifestyle and 6 were about heart failure medications. They were all covered in the material. This assessment was designed by heart failure clinicians and especially heart failure nurses in our clinic that felt that these were important elements for patients to know about their medications and their blood pressure and weight monitoring. We assessed participant preference for video versus text via the Likert scale, as well as participant self-assessment of knowledge. The primary outcome was the change in heart failure knowledge score for video-based questions versus text-based questions. The co-primary outcome was participant preference for video versus text-based education. So in terms of the trial flow, we aim to enroll any participant with heart failure with reduced ejection fraction less than 50% with either a recent or upcoming Stanford Heart Failure Clinic visit. We enrolled 129 individuals who consented over email, completed the intervention at home. 101 of those completed the intervention and were included in the final analysis. And then we enrolled another 29 individuals in clinic who actually completed the intervention on an iPad in clinic for a total sample size of about 130. Here are the participant characteristics compared to those who did not consent but were active in our clinic. You can see that participant characteristics were relatively similar. Those who consented and completed the study were a little bit older with a median age of 69, compared with those who didn't consent to the study with a median age of 65. The median ejection fraction was 35%, and about 1/3 were women. Here's the participant characteristics by randomization arm. Again, the randomization arms are whether you got educational videos for the medications or the lifestyle and which one was first, but all participants received education about both the medications as well as lifestyle. On to the results. We saw a significant increase in knowledge on the knowledge assessment for participants overall, as well as for the medications and for the lifestyle-specific questions. We saw a lower initial score on the medication questions with a larger delta after the intervention. When we stratified by medications versus lifestyle, by video versus text, for both the medications as well as for lifestyle, we didn't see any significant differences in the change in knowledge score, whether patients got educated in that modality via video or versus text. When we combined those together, we found there was not a significant difference in the probability of a correct answer depending on whether you got video or text-based education, with 95% confidence intervals that were either 2% lower or 5% higher probability of a correct answer with video-based education. When we looked at participant preference for educational videos versus text, we saw significantly more participants preferred video-based education compared with text. About 40% preferred video-based education compared to about 20% with text, and 30% that had no significant preference. When we stratified by median age, the results were consistent with no heterogeneity across median age. So in conclusion, we found that heart failure education delivered either via animated videos or text-based infographics can improve patient knowledge. Knowledge attainment was similar between animated videos and text-based infographics. Participants on average preferred animated videos over the text-based infographics, but preferences varied substantially, and I think that's really important when we think about the design of digital health interventions. Finally, and probably most importantly, we're going to be testing the effects of these videos in addition to the other aspects of patient activation in our ENGAGE-HF app across 3 upcoming trials, as I've mentioned, the ENGAGE-HF trial, the OPT-HF trial in Brazil, and the GROW Rural trial in rural Idaho. And we're really excited to share what those results are over the next 1.5 years, hopefully at sessions. Thank you, everybody.